The following podcast was recorded at the ANZICS Safety and Quality Conference 2014, Rapid Response Teams. In part one of a two-part debate, Robert Herkes argues that ward doctors should manage their own deteriorating patients.
At lunchtime I had to go home and change my talk. I'm going to talk about why ward staff should manage a lot of their own deteriorating patients and ICU should help, but the issues about ward staff and wards and how wards cope with deterioration rather than ICU. And really the elephant in the room is appropriate staffing and the amount of staff you need to run a proper RRT in our increasingly complex hospitals. And just because I can look at Star Wars 2, there's the modern equivalent of the elephant in the room. Now, yesterday and today I've been accused of being a father and a grandfather of this and a grandfather of that. And what I wanted to tell you was what wards were like last century. Now, most of you won't believe I was a junior doctor last century. And the first ward I was sent to was 12B at Royal North Shore. And 12B at Royal North Shore was a 25-bed ward, and in those days it was an endocrinology ward. Now that was great, but you know what the patients were in there for? They were in there for short synaptin tests, they were in there for random glucose tests, they were there for morning cortisols. They were essentially patients who were walking around, feeding themselves. You know, there used to be things called patient lounges on wards. That's because the patients used to be able to walk up there and watch telly. Completely different to what's in our hospitals now. And one of the problems is that our hospitals haven't adapted to that. Now, this is my caveat thing. The things I'm about to show you suit my teaching hospital. You may have a teaching hospital that these ideas suit. You may not. They certainly won't suit smaller hospitals. And you really have to consider what your own structures are, what your governance is, what your levels of staffing are when you're designing your rapid response team. Now, I put it to you that what we've been talking about for the last 2 days is building a fire engine, okay? And we've built this fire engine, and this fire engine goes out to the ward from the ICU to rescue people. But what we really ought to be doing is putting in a sprinkler system in the ward so that the fire doesn't get out of control and the fire's controlled. Now, this happens to be the sprinkler system that's being installed at Quakers Hill Nursing Home in Sydney. Now, many of you will have heard that unfortunately there was a fire at Quakers Hill, and they had old-fashioned technology, as in fire reels, but no sprinkler system, and 3 people died in the fire and another 8 died subsequently as a result of a probably incapacitated staff member setting fire to an empty bed. Now, I put it to you that, in fact, this is an analogy for what we need to do for our hospitals, that we're running on last century technology in our wards, we're running on last century organisational structures in our wards that haven't kept up with the times, haven't kept up with the changes, and we're building a rapid response team, the fire engine, to rush down the street to save the people, when in fact we should be looking at re-engineering what we do in the wards, just like putting in a fire sprinkler system so that things don't get out of control. Now, what I'm proposing is a clinical emergency response system rather than a straight MET team. Now, there's a philosophical decision here. A MET team, as we all know, becomes an ICU issue, and the mantra is the wards can't triage properly and they can't learn, therefore the ICU has to look after the sick patients, even the quasi-sick patients in the wards. There are some advantages in doing that. You have the same escalation policy all the time, 24 hours a day, 7 days a week. You just call the ICU. The ward escalates, so you only need to teach the ward staff how to escalate. You don't need to teach them about how to treat. You only have to educate a limited number of ICU staff about how to treat a deteriorating patient. And you've got a small team of responders, the ICU doctors and nurses. What I think you should think about is a clinical emergency response system that includes the ward staff. I believe the wards need redesign, and ICU can help with that redesign, but in the end it's a ward issue. And the problem with doing what I'm suggesting is you need different escalation plans in each ward for every hour of the day and night. You need to educate all your staff, just not the ICU staff, in how to recognise and then respond to a deterioration. But the advantage is, instead of just having the ICU doctors and nurses as a team of responders, you've got all the pool of hospital doctors and nurses. And in PA, as I said yesterday, that consists of 35 different teams of doctors and nurses. Now, so what are the characteristics of MET versus modified SIRS? A MET has an emphasis on response and resource provision, and all of us have heard a lot about where's the money coming from. The natural conclusion from increased activity for a MET is to push for an expansion of the MET and therefore more ICU resources. Well, that can't be a bad thing. The primary care team has a perverse incentive not to anticipate deterioration and to outsource response work to the MET. So the patient's hypotensive, well, I couldn't be bothered about it, call the MET. Or they're looking a bit unwell, they're tachycardic, call the MET. The ICU slowly takes over more and more of the clinical management in ward areas. And I think that's inappropriate because you're rushing in, doing a band-aid therapy and then leaving again without actually working out any long-term plan for that patient. End-of-life management's initiated and conducted by teams who are unfamiliar with the patient or the patient's relatives. And the responsibility and work of responding is concentrated in that small number of staff. What I think we should be doing is having a clinical emergency response system based on the wards with the ICU helping out. So the natural conclusion of increased system activity is to push for extra ward education and reorganise ward cover, day versus night, reorganising where the teams are, who's in theatre, who's not in theatre, making sure there are staff out of theatre and what have you. The primary care team in that sort of system has an incentive to anticipate and prevent calls rather than just slough them off to someone else. I think in the end, in 10 years' time, what we'll see is most of the wards will work like HDUs, where there'll be geographically located teams of senior doctors and nurses who look after the patients in that area, and the SODs, the single organ doctors, will come along and comment about whether or not you're giving the patient enough proton pump inhibitor for their gastric ulcer and whether or not they're going to endoscope them today or tomorrow, just like they do in an HDU, and the day-to-day, minute-to-minute care will be looked after by people who know about it, who are located on the wards, and whose job it is. Now, the problem with that is, at a senior doctor level, there are 4 groups of doctors that could do that. General physicians, but hey, we don't train any more general physicians. It's very unpopular with the College of Physicians. No one puts their hand up for it. We could use emergency doctors, but lots of emergency doctors see themselves as roster fodder and probably wouldn't go for it. We could use geriatricians because they still see a broad range of general medicine and some of them might be interested, or we could use intensive care doctors. And so for people training, that may be where, in the end, lots of ICU doctors end up working part of their life running an HDU on the hospital wards. In my model, end-of-life care management's initiated and conducted by the primary care team, not by the ICU, and the responsibility and work for responding is distributed among a large number rather than a small number of clinical staff. Now, our system has at the moment about 20 calls a day, which is distributed between the ICU and the medical and surgical registrars of the hospital. The average call duration is 35 minutes. But you can have up to 4 calls simultaneously and the system can cope with that because there's lots of people in the system. Even at night time you can have 4 calls simultaneously and cope. Who's available? When you're designing your system, you've got to decide who's available in your hospital to take us the MET or the RRT load. And you have to decide what the benefits of using ICU staff or ward staff for those roles. So clearly ICU staff have excellent resuscitation and procedural skills, but there aren't all that many of them and they've got a significant workload in their home ward, the ICU. There are lots of staff in the wards, so there are large numbers of staff. Often they have highly skilled subspecialty skills, so the cardiologists will beat my registrars at sorting out how to treat an arrhythmia almost any day. But my registrar will beat them putting in a central line to give the amiodarone. The other thing about ward staff is clearly they know their patients and they've rounded on their patients and they can tell whether their patients changed from their last round. And they work as a looser team than the ICU team usually. So ICU staff, as we've heard in this conference, are out of their comfort zone when they're on the wards. There aren't any monitors, there aren't any lines, they don't know who the staff are, they don't know where anything is. They often have little subspecialty knowledge, so when my registrars go stomping into the oncology ward, in fact it's much safer for the oncology patient to have the nurse practitioner sort out the rapid response than it is to have my registrars who go and contaminate the area with MRSA and God knows what else. And often they have the ICU registrars have no previous knowledge of the patient or their treatment. Ward staff have a lot of those attributes, and they can deliver subspecial treatment, but they're clearly not as good at resuscitating people, which will be Ken's point, I'm sure. What are the calls about? We've already heard that the bulk of calls are for things like hypotension. In our series, 25% of calls were for hypotension, 19 or almost 20% for respiratory rate of above 24, and so on. Interestingly, the number of concurrent triggers, 75% of our patients only had a single trigger, 20% had 2 at the same time, and 4.8% had 3 at the same time. And we have this system where the staff have mandatory triggering, but discretionary levels, so the staff can decide whether they're going to just get the ward team or the ICU team. And importantly, from our point of view, they do seem to select the ICU team when there's more than one trigger criteria going on, and that's completely discretionary on their behalf. What happens? In our system, 71% of them are stabilised on the ward, 6% come to ICU or HDU, so most of them get stabilised. And again, as I said yesterday, if you look at which wards they're in the haematology ward and the cardiology ward, and those wards are well staffed and have lots of doctors and nurses around all the time. A smaller number, but a significant number in orthopaedics, and clearly the current surgical models don't serve ward patients very well when all the surgeons and all the trainees and all the registrars are off trying to get some cutting in theatre. And that's the stuff we need to re-engineer. When you set up your SIRS committee, you need an extraordinary broad range of people. And if you're going to do it for the whole of hospital, you need a lot more than just ICU. And as you can see, that's our SIRS committee. There's lots and lots of non-ICU people there, including 4 medical registrars, a surgical registrar, the medical superintendent, and so on. So you need a broad range of people from the hospital to get buy-in and to oversee governance. And essentially, if you're going to do a SIRS, it's education, rearrange, educate, audit, rearrange, educate. Nurses need vital sign education. As I said yesterday, in our hospital, the director of nursing at one stage decided respiratory rate was a waste of time, so she got rid of that. We went around and audited what time observations were taken, and there's something like 40 wards in the hospital, and there were about 30 different times that people did QID obs. So, some people woke patients up in the middle of the night, other wards didn't, and so on. So you have to standardise all that stuff. One of the most amazing realisations to me was that when you go to the ward and ask a nurse how they do respiratory rate, they all take out their mobile phone because none of them have watches anymore. All right, and so the hospital's going around trying to stop people bringing their mobile phones to work. But hey, the only way anyone has any idea how to measure respiratory rate or pulse rate is to pull out their mobile phone to give them the time. So there are all sorts of counterintuitive things that our hospitals are doing that in the medium term are dumb. As I said, you need to educate the medical registrars and you need to audit the system. Now, wrong way. Does it work? So this is our ICU dose. This is New South Wales data. One of the other things, and it's an observation about this conference, is governance is vastly different in each of our states. So in New South Wales, we had mandated between the flags, That meant every hospital for the last few years has had to have an appropriate system. And Ken's done a lot of work getting statewide data. This is some of the statewide data. That's the ICU calls in our local health district, which is Prince Alfred and Concord and Canterbury hospitals. And you can see that's below the average number of calls for our other hospitals. And this is the in-hospital cardiac arrest rate, and our rate is at right on the average. And in fairness to Ken's is lower than the average. So there you are, being nice, Ken. So one design doesn't suit everyone. I think we've got a two-tiered problem. We've got to have a response system now, which means we do have to build the fire engine, but in the end we have to re-engineer the ward and put through the sprinkler system, so the fire engine hardly ever needs to come out. And so I think that the important part is thinking about, in the medium term, how we redesign the care of patients on the wards so that deterioration is taken care of more appropriately. And my personal view is we should be moving towards making all the wards look a lot more like an HDU.
For more podcasts from ANZICS, go to anzics.com.au.